Hello viewers, in this video I am going to cover cholinergic antagonists. Cholinergic antagonists can be divided into two main groups, that is anti-muscarinic agents and anti-nicotinic agents. Anti-nicotinic agents are further subdivided into ganglionic blockers and neuromuscular blockers. In case of anti-muscarinic agents, we will talk about different drugs like atropine, cyclopentolate and tropicamide. There are some other very important drugs belong to anti-muscarinic agents are tiotropium and ipratropium, which are used in COPD. Based on their mechanism of action, neuromuscular blocking agents are classified as either depolarizing or non-depolarizing neuromuscular blocking agents. Let's start with anti-muscarinic agents. These are also known as anticholinergic drugs. These agents block primarily muscarinic receptors, thus they cause inhibition of muscarinic functions. One of the most well-known medication that belong to this group is atropine. Atropine's sites of actions are eye, GIT, heart, salivary glands, sweat glands and lacrimal glands. Now, anti-muscarinic activity of atropine in eye results in relaxation of ciliary muscles, which causes dilation of pupil and cycloplegia. That is, what is cycloplegia? It is the inability to focus visually, or you can say unresponsiveness to light. Because of long duration of action of atropine, other anti-muscarinic agents are preferred, such as cyclopentolate and tropicamide. Cyclopentolate and tropicamide can produce mild rashes that last for hours, while atropine's effects can last for days. Another feature of atropine is that it blocks M3 receptors in GIT, which results in reduction of GIT motility. This leads to prolonged gastric emptying. After a meal, it normally takes 1.5 hours or 2 hours for food to move out of the stomach and goes into the small intestine. When your stomach takes longer than normal to empty, it is called delayed gastric emptying. At higher doses, atropine can also effectively block M2 receptors on sinoatrial node and atrioventricular node, which produces tachycardia. Lastly, by blocking muscarinic receptors on salivary glands, sweat glands and lacrimal glands, atropine produces dry mouth, dry skin and ultimately causes body temperature to rise. The next medication in the anti-muscarinic group is scopolamine. Scopolamine has a much greater effect on CNS and also have a longer duration of action. For that reason, scopolamine is one of the most effective medication used for prevention of motion sickness and post-operative nausea vomiting. Other anti-muscarinic drugs which are very important are ipratropium and tiotropium. Ipratropium and tiotropium are non-selective muscarinic receptor blockers. They block all subtypes of muscarinic receptors. This results in decreased contractility of smooth muscles in the lungs, which in turn leads to bronchodilation and reduction of mucus secretion. Tiotropium and ipratropium are administered by inhalation for the treatment of bronchospasm. These are commonly used in COPD. There are some other medications which are antimuscarinics and they are used for the treatment of overactive bladder. These drugs include tolterodine, darifenacin, solifenacin, oxybutynin, and trospium. Darifenacin and solifenacin and trospium are considered to be selective M3 receptor blockers involved in the treatment of a hyperactive bladder. Now we can move on to the second group of cholinergic antagonists, that is ganglionic. We will talk about nicotine, which is a main component of cigarette smoke. Although nicotine is a cholinergic agonist, but it is also considered to be functional antagonist of cholinergic receptor because of its ability to stimulate and then block cholinergic functions. Nicotine acts on the nicotinic receptors of both parasympathetic and sympathetic autonomic ganglia. Effects of nicotine result from increased release of neurotransmitters such as dopamine, acetylcholine, and norepinephrine. Due to the release of dopamine, nicotine causes drug-induced feeling of pleasure and later on addiction. Acetylcholine plays a very important role in cognitive functions. Ability of nicotine to increase norepinephrine activity might contribute to the increased level of alertness. Nicotine also acts on nicotinic acetylcholine receptors in the peripheral nervous system, that is sympathetic ganglia, where it can lead to increased sympathetic nervous system activity, like an elevated heart rate and blood pressure. It also causes the increased release of catecholamines like epinephrine from the adrenal glands, which can further enhance the sympathetic activity. Although nicotine first activates nicotinic acetylcholine receptors, it subsequently causes the receptor to become desensitized. As more receptors become desensitized, the brain tends to add on more acetylcholine receptors, and these increased receptor numbers play a role in the withdrawal and craving that occurs when nicotine administration has ended. Now let's talk about neuromuscular blockers. Neuromuscular blocking agents simply block the cholinergic transmission between motor nerve endings and nicotinic receptors on the skeletal muscles. So if we zoom in on this part where nerve endings meet with the skeletal muscle fiber, acetylcholine binds to the nicotinic receptors and induce their opening. Opening of these channels lets sodium ions to enter the muscle fiber and trigger muscle action potential. The potential travels along the surface of sarcolemma, that is the membrane of the skeletal muscle fiber that surrounds myofibrils. Then the action potential travels through T-tubule system, which are the invagination of the plasma membrane, and then the arrival of action potential causes calcium to be released from the sarcoplasmic reticulums, which finally leads to the muscle contraction. Now let's talk about the non-depolarizing agents, which are atracurium and rocuronium. First, these agents are competitive antagonists. They bind to nicotinic receptors, but they do not induce ion channel opening. What does it mean? That they prevent depolarization of muscle cell membrane and thus effectively inhibit muscle contraction. In clinical practice, these agents are used to increase muscle relaxation during surgery. Time to onset of action of these agents is rapid. usually less than 2 minutes. Once administered, these agents paralyzes small and fast contracting muscle first, that is eyes, face, fingers. Then larger muscles of neck, trunk and limbs, and lastly the diaphragm. On the other hand, these muscles recover in reverse manner, that is diaphragm first, then limbs, then trunks, and so on. Now some of the most widely used agents in this group are cisatracurium, which has clinical duration of action of about 90 minutes, pancuronium, which also has clinical duration of action 90 minutes, rocuronium, which has duration of action of 40 minutes, vicuronium, which also has clinical duration of about 40 minutes, and lastly atracurium with 40 minutes clinical duration of action as well. Now let's move on to the depolarizing agents. Now let's move on to the depolarizing agents. Depolarizing agents act as an acetylcholine receptor agonist. They mimic the action of acetylcholine. However, they are much more resistant to degradation by acetylcholinesterase and therefore produce a persistent depolarization. Now, the only depolarizing agent that is still in clinical practice is succinylcholine. So, succinylcholine binds to the nicotinic receptors, and unlike the non-depolarizing agents, it actually causes the sodium channel to open, which results in membrane depolarization. Now, because succinylcholine is resistant to acetylcholinesterases, as I have told you earlier, it causes prolonged duration of action, which leads to the transient fasciculation or muscle contraction, and finally flaccid paralysis. This is referred to as phase 1 block. Now eventually sodium channel closes and membrane repolarizes due to continued stimulation by succinylcholine. The receptor becomes desensitized to acetylcholine, thus preventing the formation of further action potential, and this is referred to as phase 2 block. Succinylcholine causes complete muscle relaxation within 1 minute. The effects typically last up to 10 minutes due to the rapid redistribution and hydrolysis by plasma pseudocholinesterases, and this is the cause of adverse degradations in the patients generally deficient in plasma pseudocholinesterase genetically. Now let's talk about the ADRs related to the anticholinergic drugs. We will try to remember with the help of mnemonics.